following is a production of West Virginia Public Broadcasting.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
Welcome to Doctors on Call. Tonight's topic, cystic fibrosis. Two experts are here to answer your questions. Now here's your host, Dr. John Phillips.
Good evening. Cystic fibrosis is an inherited disease that causes thick mucus to build up in the lungs and digestive tract. Often known by its initial CF, cystic fibrosis is one of the most common chronic lung diseases in children and young adults. CF can result in early death for some patients, but with more than 1,000 mutations to the gene that causes it, CF symptoms vary from person to person. How do you know if you are a carrier of the CF gene? How is the disease diagnosed? Are there any new treatments on the horizon? We'll get answers to these questions and more from our two guests, Dr. Maple Landvoigt, a pulmonary medicine specialist at WVU's Children's Hospital, and Dr. Kathy Moffitt, an infectious disease specialist at WVU Children's Hospital, and of course, a frequent host here at Doctors on Call. If you'd like to ask our guests a question, give us a call. Our phone lines are open now. Maple, let's start with you. Can you explain what is CF?
Well, as you mentioned in the lead up, CF is a genetic disease, and so it's a disease that you're born with, but the symptoms are quite variable, and so some children will present early in life with lung disease, also GI disease, difficulty gaining weight, and other children will do well until they're older and may have more mild symptoms, just such as sinus disease or milder lung symptoms that might present like asthma.
Okay. So obviously lots of different ways to diagnose it.
Right. So the classic way is the sweat test, because one of the problems is there's more salt or chloride, in sodium and chloride in the sweat, and so you do a simple test where you get the skin to sweat and you collect sweat. But now we have genetic testing as well, so you can actually look for the mutation. And like you mentioned, you only need to have 2 mutations. So this is an autosomal recessive disease. So it's inherited on chromosome 7, and we have pairs of chromosomes, and 7 you get one from your mom and one from your dad. So if your parents are carriers, they have one normal gene and one CF gene, and so they're healthy. And when the fetus is conceived, the CF gene from the father and the CF gene from the mother and number 7 go together, you have CF. So you can actually test for that gene, the DNA mutation, we call it.
So Maple, if we know that's a genetic disorder, should everyone be tested genetically for the disorder?
Well, genetically, probably not. The genetic tests are quite expensive and not necessary for actually to diagnose most patients. But we do have newborn screening that uses a 2-step method that initially screens for an elevated enzyme in the blood that's been associated with CF. And now all babies born in CF, born in the state of West Virginia now will be screened for CF that way. And then if there's a suggestion that they might be a carrier or might have CF, then they will go on to full genetic screening.
Okay,
right.
Very good. They'll be referred to you.
Right, and so now actually it's nationwide. West Virginia expanded newborn screening in March of 2008, but as of the end of last year in December, the last state got on board, and so every baby now born in the U.S. and all the territories is screened for CF. We're not sure it's going to pick up every single child, maybe not the mild disease, we're not really sure, but most of the classic CF is probably going to be picked up at birth.
Very good.
Which is exciting.
Well, we're talking about cystic fibrosis tonight. If you have any questions, please give us a call. So Maple, it's important for us then to make the diagnosis early for children. Why is that?
It is. For probably about 20 years now, we've known in the cystic fibrosis community that the children that are found at birth and immediately started on treatments to help with airway clearance, to help with digestion and help absorb their calories and help with growth, do much better in the long run than children that are not picked up early and sometimes have some of those problems, not being able to gain weight appropriately, not, we think, developing perhaps even as much lung tissue as children that have better nutrition.
And for those that aren't picked up with genetic screening, at what age will they typically start to show symptoms?
Well, about 90% of patients that have cystic fibrosis have trouble with their pancreas and are what we call pancreatic insufficient. And that's a problem that makes it hard to absorb fats, and it makes it hard to digest your food. And so many children will present between 6 months and a year of life with difficulty gaining weight. Pulmonary symptoms and sinus symptoms typically present a little bit later, starting at about age 2, and then can present really at any time throughout life after that.
If you look at the registry data, so the Cystic Fibrosis Foundation was founded by pediatricians and parents wanting to learn more about this disease in the early 60s, and so we have a registry, and we're one of the 117 care centers in the U.S., so we participate in the registry, and this is how we learn things. So patient information goes in the registry, and one thing you can look at in there is at what age are people diagnosed? And classically, most children, it's about 18 months to 2 years of age with classic symptoms. So a pediatrician, a family practitioner, an ER physician, an ENT may see this child who's not gaining weight, who's had frequent infections, and think, should order a sweat test or DNA. Now the age is being lowered, though, because we're diagnosing many more children with newborn screening. Okay. But it's really fascinating to look at that, though. We have, also many older teenagers and adults. We've made diagnoses in adults with CF because they're the ones who don't necessarily have the digestive problems, but then go on to have the pulmonary and sinus problems, and somebody thinks about CF in them.
Yeah, so a lot of our audience is adults, so it can be diagnosed later on in life, obviously, not just with poor weight gain. What are some things that older folks should watch for, or maybe think about CF if they have what sort of symptoms?
Yeah, absolutely. So many of the older patients that I see in the adult CF center come to us with primarily sinus disease and typically some respiratory symptoms, but it's quite variable. Really, all patients with CF, no matter sort of what variant that you have of CF, have some respiratory symptoms, but that can be anywhere from more focused on sinus symptoms and a lot of sinus problems throughout life, perhaps even something called sinus polyps that are somewhat concerning and should be looked into further if those are found, warrant further testing, I should say. But then also even mild respiratory symptoms that, again, may have presented something like asthma, chronic cough, trouble clearing infections. So patients that get a cold and everybody else in the family gets better in a few days or a week, but it seems to linger on for a couple weeks and it's harder to get through. Those are some of the common kind of symptoms that can present with the more milder forms of cystic fibrosis.
Right. And I had a patient a few years ago who had been through a big infertility workup as a male, because nearly all males are infertile with CF. Women, it's a relative infertility. We've had a lot of women recently who have had pregnancies and babies, but this gentleman was in his 30s and he had been through infertility, and he and his wife had twins from in vitro fertilization. And it wasn't until he was admitted with pneumonia that one of the adult physicians thought about, could he have CF? And he called me, and then we ordered a sweat test, and we were able to show that he did. He also had a trouble with recurrent pancreatitis, which is inflammation of the pancreas. So he was born with his pancreas functioning, but as he got older, his pancreas became inflamed and he'd get these chronic pain attacks with pancreatitis. So not all pancreatitis is CF, but someone who doesn't have any other risk factors and gets recurrent pancreatitis, you think maybe and he eventually became pancreatic insufficient as his pancreas kind of shrivel down.
And then did he have some sinus symptoms
He didn't really have sinus, but he had respiratory symptoms. And he said he would get a bronchitis every year, 2 or 3 times a year, and then a cough that never went away. And at times when he was ill, he could produce sputum. Now, I have never coughed anything up, even when I've had bronchitis. I think maybe men are better at it than women. But I think if a kid or a teenager is able to bring up sputum, I think that's unusual. I think it warrants some investigation as to what is going on in that child. And CF may be one of many reasons, but...
Sure.
Yeah, and I would say from the pulmonary perspective, absolutely, if you have a younger child, particularly an infant or a toddler that is able to produce sputum, that is abnormal. That's not a typical, doesn't mean that you necessarily have a problem if you are able to, but it's unusual. And in a clinical picture that is suggestive with some of these other symptoms that we've been talking about, definitely warrants further evaluation.
So it's a full systemic issue, right? The sinuses, the lungs, infertility. And
CF actually does affect every organ in the body to some degree. There's many other problems besides just lungs and pancreas. For instance, liver disease is sometimes an important part of some patients with CF's picture.
Well, we're talking about cystic fibrosis tonight. If you have any questions at all, please give us a call. Our 2 experts are waiting for your questions.
Yeah. So I had a teenager who hadn't been diagnosed, but he was kind of a skinny guy, and he had asthma and a lot of respiratory symptoms, and he got dehydrated in the summer. It was really hot, and he was working outside and wasn't drinking enough fluids, and he sweat a lot of salt because that's how we diagnose CF. We can't change that. We just tell our patients they need to keep up with fluids and salty snacks. So he was diagnosed when he was taken to the emergency department with dehydration, and they thought, this is a little unusual, have lost so much salt and be so dehydrated. And so sometimes it's, that's extremely rare. But it is a systemic disease.
But dehydration is, being prone to dehydration is an important part of cystic fibrosis. And it's interesting, actually, that one of the original studies that was done in CF that led to the development of our current diagnostic testing, the gold standard, which is the sweat test, was in the 40s and 50s. There was a physician named Desagnis in New York City, and there was in particular a particularly bad summer heat wave in New York City, and he had a number of children that had the symptoms. They didn't really fully know about CF at that time, but they had symptoms of CF that the physicians there were aware of, and many of them were coming in with dehydration, and that led him to look more into the sweat gland and why it was that they were losing so much salt.
You talk about the sweat, the salty taste. We do ask parents when we're making a diagnosis, does their child taste salty? Now, some people have heard that and then will say, oh, my child really sweats, and it turns out they don't have CF. Right. But that is something that we look at, and if they excessively have salt rings on clothes or on hats, more than what you'd normally have in the summer, you think about CF.
Very, very interesting. Well, we have our first caller. It's Carol from Monongalia County. Carol, welcome to Doctors on Call. Do you have a question?
Yes, I had a question. I had been reading about some gene therapy trials that were going to start on patients that had already been diagnosed with CF to try to use some gene therapy to help them, and I just wondered how that was going to help them out.
Very good. So we haven't gotten into treatment just yet, but let's jump into gene therapy.
Well, gene therapy has been a disappointment. We really thought in the early, mid-90s the gene was found for CF in 1989, and I remember we said 10 years and we'll have a cure, we'll have gene therapy. And unfortunately, they figured out what the defect is, and they figured out what you could do to correct it, but haven't figured out the key to deliver it to the cells, because delivery has to be, it gets destroyed once it gets in the body. And they've tried different vectors or different ways to get it in, and the body is smart and sees that and just halts it.
So gene therapy is taking normal genes and introducing it to a person with abnormal genes.
Exactly, and as Kathy mentioned, the key there is how to get the gene into the into the cell. Since we know what causes CF now, how do we get that there? And one of the troubles in CF is that it does affect every part of the body, and so getting the DNA to each cell that would need to be corrected, it makes it more difficult than some other diseases. In general, some of the problems with gene therapy have been the vector, as we mentioned. When we say vector, that's a virus that's used to carry the DNA into the cell. And the problems tend to be either it will work for a short period of time, but the cell won't continue to use that good gene. It'll go back to using the original gene that it had. Or the virus itself can have some side effects and cause some irritation and inflammation, and the body can react to that and sees it as abnormal. And so that may limit its effectiveness long term. There aren't currently large studies in gene therapy going on in this country. There are a few that are in Europe that are being worked on. Right now, in this country, what we focused a little bit more on are some correctors of what's called the protein that's one step down. So after the cell takes the DNA that you have from the gene that we know what it is, it makes a protein that we also have identified, and that protein doesn't function normally. And so we actually have a number of new therapies that are in clinical trials right now, both in this country and even some around this state. There's some opportunities for that, those clinical trials that actually help to correct the way that protein works. And actually, for the first time ever in the history of CF, we'll start to be able to correct the actual underlying defect, not just treat the symptoms.
So that's a cure for CF, but until then,
well,
what do we have to offer these patients?
Well, it is very exciting. I think we work as a team. So we have a social worker and a dietitian and a nurse and an exercise physiologist and a pharmacist, and we work together, and we work with the family and the patient. We're all part of the team. And we've really made a lot of progress in understanding how difficult it is to do all the medications and all the therapies that we ask, being more aggressive at identifying when someone is sick. So we measure lung function, we look for infection, we watch for weight, and if the weight isn't good, then we're proactive about getting more calories in, about seeing how they take medicine called enzymes that help digest the food. Are they taking the right amount? Are they able to swallow the capsules? A whole lot of approach of really being very proactive, meaning we're anticipating things, we're looking for things. We see patients very frequently, and we don't want to let things slide. We don't want to just say, oh, you're coughing and your lung function's down a little bit. We'll wait and see how you are next time. No, we're going to treat you, and if you're not better, then kids and adults get hospitalized.
So this comprehensive care, as well as the newborn screening, has certainly changed our outlook for patients who have CF. So what exactly can be expected?
Absolutely. In her seminal paper by Dr. Dorothy Anderson in the late 30s, who first really identified cystic fibrosis as we know it. At that time, children often died in infancy or early childhood, although quickly they made some strides there. But up unfortunately, through about the next 40 years, up through the 70s, there wasn't a lot of progress made in terms of really improving the lifespan of children with cystic fibrosis. And I say children because at that time, people often died in childhood. It was not uncommon to not live through your teenage years. That's not true anymore, I'm happy to say. As you said, due to the comprehensive care approach that we do now, and some newer treatments that we'll probably talk about that have come up even in the last 15 to 20 years, most children now are expected to live into adulthood and through middle adulthood. And the average sort of age that we're projecting for the kids that we take care of now is to at least live into their late 30s. But with some of the newer therapies that are coming along now, we certainly hope even much more along the lifespans than that.
Sure. Yeah, I'm hopeful that we say to a baby who's born now and picked up by newborn screening, and we're making this diagnosis, and it is a devastating news for parents and families to hear, but to say, well, where are we going to be in 20 years? So we keep your child, we've identified your child, we keep them healthy, they play sports, they graduate from high school, make plans for college and marriage. Maybe in 20 years, there's going to be something then that we're going to project that the lifespan's going to be, for the classic CF, maybe 60 or 70 years. So, and then we have it's very inspiring because you come to clinic and people go, this is pediatrics, and we have these adults. We have an 83-year-old. We have some in their 60s and 50s. So, you know, it's not just a pediatric disease. Half of our patients, almost, aren't they, Maple, now are adults?
And actually, nationally, that's soon the projection as well. As of in the next couple years, actually, most patients are going to be adult patients, no longer a childhood disease.
Excellent. So what are some of the new therapies and clinical trials you were talking about?
Well, we have two that are in clinical trials now that are targeting it's actually a chloride channel. The protein that isn't made properly in the cell is like the key that opens the channel, and salt and water can get out. And because salt and water stay in the cell, then you end up with thick mucus in the lungs, the sinuses, the digestive tract. So these two therapies target either the chloride channel that's not working properly, help it open better, or we have some other smaller channels on our cells, and the other drug works on those other ones to help them open better. So these two medications may in the next 2 to 3 years be, if they continue to be as successful as they look, be actually approved for patients.
And I'll mention just one other new drug that is coming along as well. In that vein, there is the most common mutation in cystic fibrosis is something called delta F508. And in this country, up to about 80% of patients have at least one copy of that gene. And that causes after the DNA is made into a protein, it causes the protein to be folded incorrectly, and the cell recognizes it is abnormal and gets rid of it, even though it probably does have some functionality. It would actually work a little bit if the cell would use it. And so there's actually a third class of new drug that's out that's actually going to help to sort of chaperone that protein and get it out to the edge of the cell where it can work and actually have very beneficial effects for many patients.
Excellent. We're talking about cystic fibrosis. If you have a question, please give us a call. Our number's at the bottom of the screen. So, you know what I wanted to bring up was that with all the genes,
right.
I didn't realize until earlier today that 1 out of every 8 people are at least a carrier. Maybe we could talk about carrier status a little bit more.
The carrier rate is high. It's a little lower than that, 1 out of about 16 to 20. Okay. So about 5 to 7% of the population. And it's typically a Caucasian or a white disease, although the gene is in the African American, Hispanic, Asian population.
Actually been identified in all populations around the world.
Right. But the most common is if you're...
At different rates.
Right.
At different rates. There's a higher carrier rate in the Caucasian population. Here in our state, therefore we have a little higher burden than some other areas.
So that means if you go to Walmart and you look and you count 20 people going by, one of them is going to be a carrier. Out of 100
because you're a carrier
people,
does not mean you have CF.
No.
It just means you could potentially pass that along.
Right. And so what we hear from many times when you have a new diagnosis, they'll say, well, you know, the parents and then the grandparents are sitting there, and the one set of grandparents look at the other one, and they go, well, it's not in our family. And then the other grandparents say, well, it's not in our family. And you say, you're right, because the gene can silently be passed, you know, from the parent got it from one of their parents, from their the grandparents, great-grandparents, and you never know until 2 people are carriers, and it's a 25% chance when a child is conceived to have CF. 50% chance that either the child will get dad's gene or mom's gene, but then a normal one, or even a 25% chance you're not even going to get the carrier gene. So, you know, my husband and I could both be carriers of CF, but we just don't have any children, so we don't know that we're a carrier. We've not been tested. There's no reason to test us. So it's silent until a child's born.
Well, we have 1 minute, and we have Harold for Kanawha County on the line. Harold, do you have a quick question?
I'll try to make it as quick as possible.
Okay.
It seems like I present with several of the symptoms that you've been discussing on your program, but CF has never been talked about between me and my doctors. I also have other conditions like fibromyalgia, which may make it a little more difficult to diagnose.
Okay, so we have 30 seconds.
So bring it up with you.
Absolutely, yeah. I think it would absolutely be worth if you have symptoms of this that you're concerned about. It would be good to talk to your doctor and get a sweat test.
The sweat test is the easiest, quickest way. You get the result in an hour, and it's a lot cheaper than DNA. DNA is the second test to do, but the sweat test is the one to do.
And it is definitive.
Right.
Excellent, great discussion. We've been talking about cystic fibrosis with Dr. Maple Landvoigt and Dr. Kathy Moffat. Thank you both for being with us. If you'd like more information, see your family doctor or visit our website at wvuhealth.com. For Doctors on Call, I'm Dr. John Phillips. Good night and good health.
Join us again next week for another edition of Doctors on Call. Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
This has been a production of West Virginia Public Broadcasting.